Then I would like to announce Biren Desai to his lecture, Multi-Level in Cervical Spine.
Once again, thank you very much. Talking about multi-level in cervical spine. And I don't know if I'm a little bit conservative, but we see these pictures with the calcification of the anterior longitudinal ligament and the osteophytes and the spinal canal stenosis. For me, there's no way to treat this patient with a total disc arthroplasty. So in this case, this patient will be fused in my department. We see also the wear-related multi-level disease of the cervical spine, and in this patient we see the spinal canal stenosis C5-6 without myelopathy, the disc herniation with compression of the nerve root causing sensomotoric C7 syndrome with weakness of the triceps muscle, and this patient is, in my opinion, an ideal case also for fusion, but in the past. It was an elderly patient, and so in the past he was treated with this, and we have to be aware of the adjacent segment pathology. And another case was treated in a different hospital. We see the adjacent level disease. It was a 51-year-old female with a radicular pain, C5, both sides, previous operation in a different hospital, and the adjacent segment disease. So in this case, we treat the patient with a total disc replacement with a monoblock prosthesis. There are also cases with a myelopathy, and that's funny because I'm a little bit more conservative, I told you, and I don't think that a patient with a myelopathy, in my opinion, should be treated with a TDR, even if it's a ball and socket, then more or less, and even with a monoblock prosthesis. But this is an open discussion, and I'm happy to be here and to discuss with you about these. I learned a few years back later, and I've learned don't treat any myelopathy with a TDR, and so I don't do it like this. Also from the legal side, I'm a little bit afraid of having discussions later on when the myelopathy doesn't go away. This patient here, 52 years, female, pain since 3 months, atactic gait, weakness in the arms and legs, loss of control of the bladder function, and the conservative treatment was done, inclusive the injections under CT scan, and she's under oxycodone. And you can see easily the myelopathy, the changes, and would everyone agree not to go for the TDR? I wonder. I treat the patient with a corporectomy C4 and C5 plus a plate osteocentesis C3 and C6. Even I know that the adjacent segment disease will maybe occur. I don't know. But in this case, I found it's the better way. Even here, maybe, a 46-year-old male, no pain, but atactic gait since 6 months, weakness in the arms and legs, loss of control over bladder function. So in this case, you may discuss, is it a case for a TDR? Would you go for a TDR? Jean-Yves?
I would go for decompression.
Decompression
at first and then C.
Laminoplasty? And then I don't like the posterior approach because also of the weakness of the muscles, and the approach is also a little bit, I don't like it too much. So I treat the patient in a different way. You see the myelopathy signs here in the T2. So I treat the patient with a corporectomy over the 2 segments, a plate, and in the adjacent segment, I was treating it because it was also black, and you saw it before in the MRI. I don't know if you can see it. I treated the patient with the additional CPESP below. But in this case, I think we can discuss about what to do. Next case is a 43 female, radicular pain since over 3 months. Conservative treatment was done, including the injections under CT scan, and she's also under oxycodone 3 times a day, 20 milligrams. And you can see C5-6, C6-7 is narrow, and you have the protrusion. This is an ideal candidate for the B-segmental CPESP, in my opinion, and you can treat them easily with the arthroplasty. Now another case, 30-year-old male, radicular pain. On the right-hand side, C5, C6 over 2 months, numbness, paresthesia in the thumb, and D2 and D3 on the right-hand side. And you see the big herniation in C5, C6. Also in this case, it's an ideal case for the TDR anterior approach from the left side. I also always go from the opposite side because it's much easier for me to see the nerve root and to clear open the recessus and do the oncoforaminectomy. So next case, treated with 3 levels. I don't have any MRI scans, but in this case it was also very narrow spinal canal without myelopathy, radicular pain, and also here a case, 46-year-old male patient, radicular pain. On the right-hand side, C5 and C6 over 2 months, numbness. This is also, in my opinion, a good case for the TDR. And here I show you on the right-hand side what I mean when I go from the opposite side. There are a lot of surgeons, they say I only go from the right-hand side of the patient or on the left-hand side. Some people are going from the head, so they stay behind the patient. So I go always on the opposite side where the main pathology is, so I can look better in this area with my microscope. There's another case, also 3 levels, and I don't want to bore you. I just want to show you what we do. We place the patient with a neck roll to avoid any kyphosis of the neck. We tear on the arms on the both sides, not too long and not too strong, so we avoid the reclination, and we fix the tubes, protect the eyes, and I think this is very common and also in your operation theater, the normal way how to do it. So the CPESP has a very good MRI compatibility. We can see very easily if you tell the radiologist after operation, if you send the patient to the radiologist, what they have to do, and you can see easily the spinal cord after operation, even if you do 2 or 3 segments. These are a few statistics from our clinic. We compared 2-level TDR versus cage fusion with a stay-lift cage, as a standalone cage with screws. We had 2 patients with the TDR, the CPSP, and 15 patients with a cage stay-lift, and the 12-month follow-up. And you see the brachialgia is getting less all over the time, very near to the cage fusion, but you prevent the motion in the adjacent segment. VIS is also going down from 7.5 to 2.7 after 12 months post-operation. And for conclusion, the advantage of the cervical TDR, even if you go for 2 or 3 segments, is a blunt dissection, little blood loss, the rapid mobilization, quick recovery of the patient. You can discharge the patient next day or after 2 days. You preserve the mobility in the segment, and also you have the prediction of less adjacent degeneration. You have the earlier full weight bearing and a good and excellent result in multi-level use. Homework. Right patient, right indication. You have to check. Thank you.
Thank you very much, Biren. Questions from the audience? Yes, please.
I think that there is a part of Elena in you, because I was very shocked to see 3 discopathies treated with 2 corporectomies, and with this straight neck, I think that you can do something else and you can preserve the mobility. This is for one case where I think that 50% of the audience does agree that we can do a prosthesis. The other one.
But let me ask you just at that point. If the patient has no function over the bladder and he has a tactic gain and he cannot walk, and you go for a TDR and maybe 1, 2, or 3 levels.
The second case, you had some lordosis, and I think that you could do a laminoplasty, wait, and after that, to do or not a discoplasty. I think that we have reflex. Reflex is corporectomy to fuse. This is the past. Now we have to think about and to see differently our patients and to turn around the spine. I prefer the anterior approach because it's the post-op course is so simple, and it's not simple when you go in the back. But I think that laminoplasty works very well. You can avoid kyphosis we have with laminectomy. And after that, if you have a problem with your disc, you can remove your disc, you can put a prosthesis. So I think that the first reflex to say there is stenosis very heavy with clinical signs, bladder problems and so on, yes. But our friends, neurosurgeon, they perform laminectomy, laminoplasty all their life, and it works for the spinal cord. It works for the spinal cord. It's not so good for the spine. So I think that what we can do in such case, you open the spine with a posterior approach, you wait, and if necessary, you can do a prosthesis or not. Because you can tell me, how is this man with 3 levels fusion? Is like a giraffe, je sais pas comment on dit une giraffe.
You won't see it.
Yeah.
When he stands here, you won't see it.
And another thing, when you have old people, they need, for walking, to see where they put their feet. This one, he cannot see anymore where he's walking, so he will have problem with fractures of all you want.
No. I don't agree in this
With
point.
force.
Sorry. But at that point, I have to tell you that maybe in Germany it's different. But if you treat the patient with a laminoplasty and you don't fix him, and he will have more problems afterwards, you get really problem with the law, I guess. So that's the reason why, even if I send him to the university clinic, they will fuse him in the same way. They will do
I
it
am
like
the
this.
university clinic, so you send
Yeah,
to me in Strasbourg, no problem.
Yeah. But that was the reason that I was asking you, who was treating at that point of this case. I was asking in the audience, who's going for the TDR? Or maybe different. It's interesting, and I like to discuss also. It's a good point, laminoplasty. I don't like the posterior approach. I think the patient they will have weakness in their muscles. There are some elderly patients, they have problems afterwards. You have 2 operations, and I think still you have to do 2 operations. You have to go from the front, and if the bladder function and the walking distance or the tactic gain will not get better, you get legal problems, at least in Germany.
Yeah. You see, when we speak about that, it's like in the past, we said, I do the surgery and I do the fusion. And you had so many people, they told you, why do you fusion, don't do fusion? And today, everybody wants to do a fusion. And I think that it's possible to do something else. And we have to turn around our patients. And if we can, to avoid the fusion. You show us wonderful cases with prostheses. And the difference between fusion and not fusion was tiny in your indication, because you said this is a good indication, this is not a good indication. It was almost the same patient.
But remember, the cases with the myelopathy are definitely fused. in my opinion.
Yeah.
Yeah.
And what you don't say, it was how many non-union do you have with this long fusion?
I didn't see one. So,
You say that you success always with a fusion, and I say and confess that I don't success always with prosthesis. So
Yeah.
a surgeon without complication, suspect.
Okay. The discussion could be proceed just
later on.
please, you have a question?
If I may, I would like to make a comment on this. I see points in every statement. Every colleague has some points that you can probably find applicable for your own practice, but I miss one point in the discussion on myelopathy and spinal stenosis, that is where the stenosis and where actually the damage to the spinal cord comes from. And I think there's a difference if you might have a primary anterior or a primarily posterior compression on that cord. So this is only a comment, and I think that if you would precisely look at the MRI scans, that you will be able to define differences between cases where you primarily have a compression from behind and other cases where you have that from the front. And so the question in my eyes is where you have an indication to decompress from anterior side, the difference is only small. The surgery is exactly the same if you're just talking about ACDF or prosthesis. So it's only the device that differs from these two techniques if you're not taking out the whole segment and the whole vertebral body and you reconstruct the whole spine like you did in several cases. But I think what I'm wondering about is the difference of the implant. Does it really make a difference that if you're treating myelopathy, the construct is not absolutely stable but mobile with a TDR? I personally, I'm not sure. I'm coming from the same school, and so I learned the same thing. And probably just to protect myself, I would go for an ACDF in the myelopathy and not go for the disc. But the older you get, the more experienced you get, you start to wonder if this is correct, if actually the spinal cord will not cover anyway when you take away the compression, regardless if it moves or not, because let's be honest, this is physiologic. The spine is to move, and I don't think that the myelin will not be able to recover just because the segment is moving just a little. This is the comment. My question was, isn't it important to look at the end plates when deciding to use a disc or not? I mean, this special implant or not? To my impression, this implant, the FH prosthesis, it has an anatomic shape, and so you have a contraindication for some osteochondrotic changes, end plates, whereas other prostheses, I would think there would not be a problem to implant these.
Yes, we see some different types of end plates, and especially the end plate when they are very flat. You may have problems with the anatomic shape of the disc. That's very rare, but yes, I agree. You should take another one then.
Okay, thank you very much. Okay, do you have one question anymore? Please.
That's a question to Professor Shi. I mean, the cervical myelopathy, in the majority of the cases, the narrowing is not just at the level of the disc. And we've seen this a lot, and we see it with the CT scan and MRI, and you see that there is stenosis behind the level of the body. So how can you deal with that by just doing a cervical disc replacement?
There is a confusion. I did not say that you have to operate all myelopathy with prosthesis. What I said, it is that the majority of the myelopathy we see every day are coming from the disc. That means that you have other things, and in these other things, I think that first we have to decide if we can preserve the mobility. If we cannot, we do the surgery. The goal of the surgery is not to insert a prosthesis. The goal of surgery is to think and to say, reflex, no, wait. What can I do? Something else but to remove a bone. Removing the bone is a crime against the spine. So if we can respect the spine and if we can reconstruct the spine, it's certainly better than to destroy and to remove and to remove. There is another way. And before you said it's coming from the front and the back. Generally, when you have something from the back, it is only because you have a narrow space and your ligament is coming inside the canal. So if you restore just the disc height, you have nothing more in the front. If you do a corporectomy, you don't restore the disc height and you let your bulging ligament in the canal. So I think that it's necessary to have another idea on the subject and not to say, this is indication for that, this is... No, there is no indication. This is one single patient. What can we do with it? If we have to fuse, okay, we fuse, but can we do something else? And the reason of this meeting is to think differently, because if you come back home with the same ideas, you could stay in England or where you want. I think that, yeah, sure, plus for that. But the reason of this meeting is to see differently what we see every day, because when you see something every day, you don't see it anymore. And I am very happy because you will go back with that in your face and say, this strange guy from Strasbourg, strange.
Okay, thank you very much.